Can I ask one format?
Yeah, did you want to ask something, Dr.
Just wanted to
Gurpreet?
confirm that there'll be no audience participation, right? Other than in the chat, there'll be me and Mohit doing verbal, or is it the structure change at all?
It's all you basically. The focus will be on your discussion. Exactly.
I got it. Mohit, you can give me signals to let me know what direction I'm going in. Feel free.
Yeah, exactly. Well, yeah, welcome everyone. I think welcome back to another subspecialty VMR focused on clinical reasoning. I think everyone is really, really excited for today's discussion. And for those who don't know me, my name is Madalena. I'm currently a medical student and I'll be facilitating the discussion. And likely, as some of you know who have tuned into this, we have two really phenomenal guests here who are helping to make this session happen. So first, our specialist discussant is the one and only Dr. Gurpreet Dhaliwal, who is a clinician educator and professor of medicine at the University of California, San Francisco. And Gurpreet, Dr. Dhaliwal, we are just really grateful that you are here. And I'm sure we would all love to get to know you better. So I'd love if you could share something about yourself outside of medicine.
Yeah. Well, I do love medicine, so it does occupy a huge part of my time. I think family things to know. My wife is a pediatrician. I have two boys who are 15 and 17 in the midst of high school. Recently had a family trip to Spain, which was lovely, very relaxing. And probably my favorite life possessions I have is an exercise desk, or exercise bike that has a flat desk that I can read on while I'm working out. It is my beloved possession in my house.
That does sound like a great possession. What was one of the highlights of your trip to Spain?
Well, Barcelona was beautiful, so all the time was there. I think even though I'm not a soccer fan, we went to a FC Barcelona game, and just the spectacle of seeing 100,000 person stadium was a sight to behold, aside from the amazing skill in soccer.
Yeah,
it really
very cool.
Huge.
Definitely on my bucket list too.
Yeah.
And then our incredible case presenter today is Dr. Mohit Harsh, who is a hospitalist at Mercy Jefferson Hospital. And then in addition to his amazing case presenting skills, I also just wanted to shout him out for the amazing wisdom and stories he shared yesterday in the setbacks in medicine discussion about how to persevere through challenges. So he's an expert in many domains, and Mohit, we're really happy that you're here. And Mohit, if you could also just share a little bit about yourself outside of medicine, we'd love to get to know you better too.
Absolutely. Thanks so much, Maddie. And definitely a novice in many domains, trying to become an expert. So outside of medicine, I think my biggest thing, this kind of started in the initial period of COVID. I really got into houseplants and gardening. So I have, I won't show you all of them, but I have maybe over 40 or 50 houseplants at this point. It is basically a part-time job to keep them all alive. I used to never have a green thumb growing up, and now I thankfully do.
Oh my gosh, that's incredible. I've been wanting to get into that as well. Awesome. And then today we have Mukund for scribing and Shema, who will be helping us for teaching points. Shema, are you here and can you introduce yourself? I'm not sure if I saw her come in yet. Anyways, okay, let me just double check who will be scribing today, and then we can jump into the session really soon. Okay. Okay, hey Sammy, are you willing and able to scribe today?
Yeah, I can do it.
Awesome. Could you introduce yourself?
Yeah, so hi everyone, my name is Sammy. I'm a med student from the Medical University of Graz in Austria, currently doing like my last year of rotations, and I'm currently in Michigan in Saginaw and currently doing intensive care. And yeah, I'm really hyped for the session today, and it's such an honor to be amongst you all and to learn with you all together. And yeah, thank you.
Awesome. Well, if you can go ahead and start sharing your screen, that would be great. And yeah, but while we wait for you to share your screen, then Mohit, you can dive into the case.
Sure thing. So Gurpreet, I want
excuse me, can you just allow me to screen share?
A little bit of suspense.
Yeah.
I guess while we're waiting, Kiara is going to be doing teaching points. Kiara, could you unmute and introduce yourself?
Hi, yeah, so this last minute, I'm Kiara, I'm MD, I'm graduate from Peru. Actually, right now I'm very, very cold, but I'm so excited to learn from all of you. And today we have many legends in medicine in this group, so I'm super excited.
Wonderful. And Sammy, you should be co-host now, so thank you. Okay, Mohit, we are ready for you.
Awesome. Okay, Gurpreet, I want you to envision yourself. You have now transported from the San Francisco VA Medical Center to our St. Louis VA Medical Center, where you're on a team with me.
Awesome.
And we are seeing a patient with the chief concern being altered mental status.
Well, I must say, I'll just make a point. I love visiting other VAs. One of the things I've noticed is I've had the good fortune of seeing a lot of them. They all look very different from the outside VAs. You know, they have different physical plants and different layouts and surroundings. But when you get inside the VA, they look all the same. They have the same cast of characters, the same layouts, the same government issue signs and doors and doorknobs and EKG machines. So it's something comforting about being in the VA with you in St. Louis. So I'm ready to go.
Absolutely. I definitely agree with that. So a little bit of background. So he's a 76-year-old male. He is directly admitted into the hospital for treatment of an ongoing ear infection. So he has had a left, what they call an acute otitis externa, over the past 2 months. He's been seen by his primary care doctor and was referred to ear, nose, and throat surgeons for treatment. He's had a myriad of antibiotic treatments, multiple debridements of his left ear, and from the ENT evaluation, they said that this infection is not getting any better, and they wanted to admit him for IV antibiotics and infectious disease consultation.
So if I can start with that point, I think, you know, altered mental status warrants a approach that we sometimes embody in the MIST schema of metabolic, infectious, structural, and toxic. But I think the best launching off point is starting with the ear disease. So he's been given a diagnosis of left otitis externa. So the two typical ear infections that we see in urgent care are otitis externa, which is the auditory canal. That's oftentimes inflamed by people using Q-tips or in foreign body or swimming, something of that nature. And then acute otitis media, which I see much less commonly in adults compared to otitis externa, at least in my urgent care. And that has more respiratory pathogens that are responsible for it. So I think there's two premises to work under. One is that the diagnosis is correct. There is an ear infection. It's perhaps of the bacterial variety, and it's not getting better. And if it's not getting better, then we would use our familiar approaches of saying, do we have the wrong bug? Are we using the wrong drug, or is there a source control issue? So just as an example, is it Pseudomonas, which can cause this? Pseudomonas treatment is not being given, or it is spread to a place where it's not being drained adequately, like the mastoid or the temporal bone, for instance, or even invasion into the brain. The flip side is to say, you know, sometimes ear infections are hard to diagnose. Like we look in there and, you know, things are red and a little inflamed and we're not sure if it's an infection or not, but we've actually mislabeled it. And instead what's unfolding in the ear isn't an infection at all. And instead it's an alternate process, like a squamous cell carcinoma is rising in the ear, or maybe a rheumatologic condition that has a predilection for the ear, like GPA is unfolding. So I'm just trying to keep both of those realities in mind as we think through this, that the diagnosis has to be revisited or the original diagnosis is correct and it's becoming complicated.
Yeah, absolutely. So maybe let me give you a little bit more background on what's been going on the outside and a little bit more detail about this altered mental status. So like I said, he's been treated off and on over the past 2 months. He's been given courses of oral Augmentin. He's been given courses of ciprofloxacin, both oral and ear drops. And he's had up until this point 4 debridements with ENT. But he's still draining what ENT describes as purulent material and he still has ongoing pain in his left ear. He gets admitted into the hospital, and on day 3 of the hospitalization is when he develops altered mental status, where the nurse is concerned that he's not as awake, not as alert, is pretty drowsy even during the day.
Okay, so I think we have a little bit more information here. I think some people have brought up the point, just expanding on where the places are that the ear infection can spread. I mean, we do have ongoing purulence. Mohit, what's the total time frame that the ear has been? It's been 2 months, you said?
Yeah, he first noticed ear pain that brought him to his primary care doctor 2 months ago. After about 2 or so weeks of treatment from his primary care is when he got referred to the ENT clinic.
So just reminding ourselves that, where an ear infection, if it's purulent, could spread or cause complications. I think we mentioned some of them, but we talked about the mastoid, which is sort of like a back cavity of the ear canal. Children suffer from this quite a bit. It can go on to invade the temporal bone. There is a condition associated with people who have diabetes called malignant otitis externa, and the temporal bone osteomyelitis sets in. And then you can have invasion or affecting the brain. I think there's a couple ways it can affect the brain. One is just an encephalopathy, period, from an uncontrolled infection that stayed outside the brain. The other is an invasion that's gone into the brain and caused meningitis or caused a brain abscess, and those two may be on a continuum. And then sometimes you can also get vascular complications inside the brain. So you can get a septic thrombophlebitis from one of the draining venous sinuses. So all those structural things may be unfolding if this is truly an infection that's not cleared. One does wonder if the person's not getting better because, and all this drainage has happened as well, if there's anything else that might be preventing source control, or the body and the antibiotics doing the rest of the heavy lifting. And one of it may be if the person's immune system, which we require to do some work along with antibiotics, is not intact. So is there any reason to think steroids have been in the background, uncontrolled diabetes, severe malnutrition, or HIV or neutropenia? And then the final thing is, if everyone is doing everything by the book, he has an infection, the surgeons are debreeding right, the infectious disease doctors are picking right, is he suffering not from the original disease, but rather a treatment that we have given him? And this raises the specter of any number of meds he could have been getting along the way, whether they're pain medications or peri-procedural medications that are making him altered, or paradoxically, the very antibiotics that we are giving him. And there's an entity of antibiotic-associated encephalopathy. It comes in 2 or 3 different varieties. That would be a diagnosis of, not of exclusion, but we'd have to work our way into that after we were clear that all those other structural complications aren't happening.
Amazing. And one quick question I had before we went on is that, so we've learned that the altered mental status started on day 3 of the hospitalization. And I'm curious how, the fact that it started after he was admitted, if that affects how you're thinking through the differential, or that's just like part of the kind of the patient's condition right now.
Thanks for that reminder. It's hard to track his timeline, but I think that is an important detail, right? Because there could be anything from reinforcing some of those ideas that I brought up, like maybe the antibiotics that he's given are given more intensely or IV or in some way that would make them more toxic. But it could be something completely unrelated. In real life, this may just be day 3 of the hospitalization is when delirium is setting in, or alcohol withdrawal is unfolding. So we absolutely have to be, or something else has happened in the hospital unbeknownst to us. A sleeping medication has been given, or a nosocomial infection. So you're absolutely right. Like if that is the trigger point, there's been 2 months of something, and then AMS is only a postscript at the end of 3 days.
That's amazing. I love how much juice we're squeezing out of just the initial HPI. So past medical history that's relevant for him, he does have a heart failure with reduced ejection fraction. His EF is hovering around 35%. He does have a history of a prior stroke with a residual left-sided hemiparesis. He has hypothyroidism, COPD, graded as severe, and he has uncontrolled diabetes with an A1C of 9. In terms of the medications that he's on for those conditions, So he is kind of on your standard regimen of basal bolus insulin, bronchodilators, aspirin, mirtazapine, gabapentin, lisinopril, carvedilol. And then two things I didn't mention the past medicals. So he also has a history of OSA, for which he uses CPAP nightly. And he was prescribed cefepime as the antibiotic of choice when he got admitted in the hospital. That's the only new medication.
Okay. I think going through this list, you almost could think of a theory for each one of his past medical histories, perhaps making him altered or more susceptible to being altered. Just as an example, his hypothyroidism easily checked, his hyperglycemia or his diabetes, making sure it's either running high or running low as a cause of altered mental status, his COPD and OSA, making sure that he's not having elevated CO2 levels that might be responsible for some of his confusion. I think we would check all of those. And then you can almost do the same exercise with his medications. Just as an example, like excess lisinopril in the setting of dehydration might lead to acute kidney injury. And then there you have a problem with gabapentin accumulating and becoming altered, or insulin normally being dosed and having a more prolonged effect. So we can see many different connections that might happen. And I trust the team is checking all of them. I think knowing that the diabetes isn't well controlled, I just lost track of it, but the A1C I think was around 9, does increase the probability that that may be one factor in the infection not clearing well, including the entity of malignant otitis externa, where the temporal bone becomes invaded by the an ear pathogen. But other than that, so there's a lot of ways he could be altered. The medications were covered, and cefepime was mentioned. He actually has now, at this point, 2 of the 3 major classes of antibiotic-associated encephalopathy, so it's worth mentioning. One category is beta-lactams, augmentin, but particularly cefepime is a well-described entity. The second is the quinolones, also have their own form of encephalopathy that's associated with them. And then there's a third category associated with metronidazole, which he's not getting now, but who knows what's in his future with this purulent drainage. So just keeping track of that. In general, the cefepime is particularly neurotoxic when there's also ongoing AKI. So already there'll be an interest and attention paid to the creatinine when we see that.
And I'll round out the family history and all the other information. So family history really only notable as well for strokes in his father, and coronary artery disease and diabetes in his mother. Surgeries, really, he has had none besides these multiple debridements that he's had with ENT for the ongoing infection. Socially, he lives in the St. Louis area, is a Vietnam War veteran, and he is currently retired. Previously, he worked as a carpenter after his service. Socially, and actually I'll pause just to make sure they can catch up. Otherwise, he does not use any illicit drugs. He is currently an active smoker with 1 to 2 packs per day, and he quit drinking in the 90s. He has no known allergies.
So always interesting. I think this, when we hear this part of the story, sometimes it allows us to humanize the patient, and I've always really liked that aspect of things. I do admire taking the family history. I'm not sure, like in the 8th decade of life, how much you can blame on your parents anymore, but every once in a while there's a clue that's in there. But I think his parents have a lot of standard issue things that aren't going to explain this case. So all right, Mohit told us that we're at the St. Louis VA, and St. Louis, being in the Midwest, has a slightly different spectrum of pathogens than other parts of the country. I think I don't want to lock on a trigger response to think about endemic fungi and such, but I am going to here because at least I'm keeping myself open to the possibility that we're in the wrong bug category. And if we are in the wrong bug category, that means we try to shift ourselves out of the response to bacteria and say that this is a bacterial infection, and consider the possibility that this could be a virus HSV, that this could be a mycobacteria like tuberculosis, or that this could be a fungal pathogen, of which St. Louis would probably give top billing to histo. Is that right, Mohit? I don't know. And by numbers, perhaps Blasto has a good showing there as well.
Yeah, it's mainly histo, and then we get a good amount of Ehrlichia, especially in the summer.
Okay, so there's another, and I wouldn't know that one so much to be purulent or out of the ears, but one never knows on a VMR. And then I love the social history. He's a proper age for being a Vietnam era veteran. It's for those who work in the VA hospitals, it's a tremendous honor to ask people like what branch of the service they were in, whether they were stateside or overseas. I think the the World War II era veterans now are in the mid to late 90s. So there's fewer of those to ask and learn from. And then the Korea era veterans are in their 80s, and Vietnam era veterans are in their 70s and 80s as well. So the age fits with that. Comes out of the service as a carpenter. Sometimes people learn their trade in the military. The military, way before all these other institutions of education had to train people on the job, was the original place where people got the best on the job training. And so you'll oftentimes someone's here, like, I learned to be an electrician in the Navy, and then I went on to have my own electrical business, or I was in the Army Corps, and then I wound up being a contractor. And here he went on to be a carpenter in this case. Not too many diseases I can associate with being a carpenter, especially this long ago. Long in the past, when there was exposure to wood, like in the loggers and stuff, there was an interstitial lung disease called sequoiosis that would happen when people were on a lot of sawdust. But I think the carpenter gets more of the tail end of that. And the smoking, and maybe more so than the drinking, makes me at least wonder about the possibility of this being cancerous. You know, smoking and drinking are synergistic for head and neck cancers, but I think that's mostly in the aerodigestive tract, and it's a learning point for me to know how much smoking affects ear cancers in particular. So I can't comment on that. So all to say, I think, we are in the same place where we started a while back with two queries. One is why he's altered, but the bigger one, I think, is what is with this ear infection that has not resolved, and are we still in the wrong bug or wrong drug category, or even wrong diagnosis altogether?
Yeah, I really, it's so helpful to the way you've outlined, the wrong bug, wrong drug, source control. It kind of takes this very complicated issue and breaks it into a more manageable approach. I'm curious at this point, we've gotten a lot of the history. What would you be looking for on the physical exam? And at this point, where would your focus be in trying to make the most progress?
Yeah, I think, the examination of the ear, although I bet this ear now has been so distorted, and that my ability to sort of use the typical landmarks I use is going to be difficult, and I'll probably rely on the ENT services examination of what is post-operative versus ongoing infection, but definitely the ear exam. I think the head and neck exam, just to see if there's any adjacent diseases that are there, so cranial nerve exams, the ear, the oral cavity, the nose, to the extent that we can see it. Again, ENT has tools and skills to see deeper and farther. But I think as we think about other categories of disease, I sort of mentioned just candidate categories, like if there is an infection in the head and neck, is it showing up somewhere else now, so that there's ipsilateral cervical lymphadenopathy? If we're interested in an autoimmune disease like sarcoid or GPA, is there a signature of that in the lungs, which may be more chest x-ray than auscultation, but definitely using both of those together. And as we mentioned, for histo has a predilection for widespread involvement in the body, but the lungs is often one of the first place that it may show up. So I think, it's a bit of a screening to say, like, is there a rash or a swollen joint or a neuropathy that's going to give me a clue to a systemic disease that's much more than in the ear? And we've discussed some of the candidate diagnoses that can do that.
Amazing, thank you. Okay, Mohit, tell us the exam.
Absolutely. So vitals are vital. He was a little bit febrile at 38.1 degrees Celsius. His blood pressure was 130 over 70. His pulse was 76. He was breathing at 12 a minute and was satting well on room air and no distress. So in general, he is a little overweight, but not really ill appearing. I think everyone really wants to focus in on the HENT exam. Kind of what would be expected. He was having a lot of pain on the left side of his ear. So if you pulled on his tragus, he was basically screaming in pain. with that, it was very hard to actually get an otoscope in to look, but what we did see was his left ear was draining purulent material very clearly, and we couldn't even get it in far enough or clear enough to see anything beyond that. So similar to what Gurpreet said, we had to kind of lean on our ENT colleagues who were consulted to assist more. Cardiovascular exam, he had no jugular venous distension, regular rate and rhythm, no murmurs. His pulmonary exam was clear. GI exam, non-tender, non-distended. He had no ascites, no hepatosplenomegaly. Where are we at now? Neuro. So neuro exam. So his cranial nerves were intact. His left side was residually weak at about 4 out of 5. He was alert and oriented times 0, and he was pretty drowsy. He would sleep throughout the exam. You would have to kind of push him a little bit to wake up, or yell in his good ear to wake him up. When he would wake up and you would talk to him, he would follow commands, but he wouldn't really be able to respond to you. So he would have actually echolalia of speech. And I noticed as well that he had some intermittent jerking of his limbs, predominantly in the lower extremities, but he also had some intermittent flexing of his chest muscles as well. And then extremities and skin. So he had no significant rash. He had no spider angiomas. I guess here I can mention he had a little bit of posterior auricular lymphadenopathy, but other than that, there was no real lymphadenopathy throughout his cervical chain, throughout his occiput, or anywhere else on his body.
So I think we have a slight temperature, which gives us a flavor that we're in the inflammatory categories, but we've already elaborated them. Those are infection, autoimmunity, and malignancy. So that's redundant information, but definitely where we are. One point I want to mention just before I go through I've been going through the wrong diagnosis, wrong bug, wrong drug, source control. There's also another version, which is wrong host, which means that you misjudge the host in terms of immune competence. So you can have a 5-part framework on non-resolving infection, is to take at least one sideshow. There's a phenomenon that happens when people have surgical wounds and we keep debriding them and they get worse and worse and worse. Typically, I'm accustomed to seeing this in the soft tissue abdominal wall of the leg, but that is they have pyoderma gangrenosum, or a neutrophilic dermatosis, where it looks all the world to us like the right thing to do is keep cutting and debriding, but that incites even a more robust a neutrophilic response every time around, until finally someone, it took a bit of courage. I've certainly been on the deliberating part of this, where we're like, all right, let's stop the antibiotics and give steroids to actually shut down the infiltration of inflammatory cells. Just a side note that I want to park. I don't think it's the answer here, but when we do repeated debridements and antibiotics and don't get the answer. So what I'm struck by here is how inflamed that ear is. I mean, it's really striking how much is coming out of there. Puts us in the same categories that we mentioned before. I'm also wanted to make note, Mohit, the other ear was normal. Is that correct?
Yes, I didn't explicitly mention it, but that was fine. Yeah.
Okay, and then the nose and the oral pharynx, to the best of ability, they were examined?
Yeah, nothing appreciable. It was moist mucous membranes. There was no real ulceration throughout his lips or internally into his palate. Nothing at least from what we could tell on nose exam. We did have our ENT consultants in the room at the same time evaluating so that we wouldn't hurt him too much doing multiple exams, and they didn't notice anything either.
Okay, and the nose exam is of particular interest because the strongest competing hypothesis in the inflammatory category, autoimmune, is GPA. And so looking for sinus or sinonasal involvement would really increase the probability of that diagnosis. Sometimes we only see it radiologically, but just something else to keep in mind. So again, this sounds a bit like a broken record. It's plausible that he has a bacteria and he underestimated the immunocompetence of this host, and his diabetes and perhaps something else like HIV or steroids he's gotten for COPD that are not listed there have rendered him just a very tough resolution. It's possible that there's a source control issue, brain abscess, mastoidosis. But in terms of competing diagnoses, is this a ear cancer or some squamous cell cancer or head and neck cancer that is also super infected, and that is the problem? or are we in the immune category, which GPA is plausible? That's the best way I can square right now the ear problem. I assume we might be getting more cultures and imaging to figure that out further. His altered mental status we have discussed already, and I think nothing has changed, but I will add that the neuro exam had two things that were important. One was I was trying to see if there's any cranial nerve abnormalities, because that would have given me a sense that this process in the ear was invasive to some other structures. So you will sometimes see people have squamous cell carcinomas of the head and neck that start invading the cranial nerves and picking off nerves, or tell us that there's a basilar meningitis. That's not present here. But more importantly, I took note of the myoclonus that he has, these sort of spontaneous jerking movements. Myoclonus has a differential diagnosis that's almost as wide as altered mental status. For MIST, basically metabolic and toxic rule in that category. So we look for metabolic abnormalities and toxins. And he's entitled to any number of metabolic abnormalities, so we will definitely check his Chem7. But among the things that we have listed, there's also a characteristic feature of cefepime neurotoxicity to have myoclonus. He is just missing the third part of the triad, which is acute kidney injury, but if they all come into focus, that's a characteristic feature. I don't want to lock in on that because he has a million other reasons to be altered, but one to consider.
Great. Let me give you some lab work. So in terms of his hematology labs, his hemoglobin was 14, his white count was actually 8, and his platelets were 250. He had a normal differential on that white count. In terms of his chemistries, so his sodium was 141, his potassium was 4.3, chloride 106, bicarb 24, BUN was 12, creatinine was 1.3, his baseline hovers around 1.1, and his glucose was 90 when we checked. Let's see what else. I didn't write down the liver chemistry tests, but those were all grossly normal, or as Uncle Bob would like to say, unremarkable. In terms of imaging, EKG and chest x-ray weren't really relevant for the case, but he did get a CT head along with CT of his temporal bones. And that showed global cerebral atrophy and old stroke areas as well, along with left ear canal erosions. There was no clear mastoiditis or any appreciable abscess on that CT head and temporal bone.
One question about that, Mohan, I don't know if you know if it was outlined, but contrast or non-contrast?
Yeah, it was a contrast protocol because of the temporal bones.
Okay. And the other thing was, do you know if the venous phase was highlighted in the contrast phase, or did the contrast get the veins? I guess my question.
That's a good question. I don't know off the top of my head.
Okay. And the reason I ask is because among the many hypotheses we mentioned, sort of an ipsilateral dural venous sinus thrombosis, septic in this case.
Mm-hmm.
So commenting the labs don't really change things too much. There is a negligible AKI, although barely so. 0.3 is the technical definition. So I think nothing to write home about there. No wild electrolyte derangement. Not even the signatures of chronic retention of CO2, for instance. Yeah, I know. But I bit my tongue and saying AKI, Bob. that's a treacherous term in these parts, but I get you. I think the white count being 8, it doesn't change things for us, but I think the CT is instructive. So not the global cerebral atrophy, you could say it's a clue to everything that's going on, but it may be age-related changes with the superimposed damage of an infarct. And I don't want to read too much into this being a signature of a diffuse encephalopathy that he's had. I think the thing that really strikes my attention is that there's erosion. So the external auditory canal has its squamous lining, and that's surrounded by bone in different directions. Once erosion set in, it tells us that the process, which you already know is destructive, yes, could be a bacteria, but has something else that's sort of inflammatory in nature. And cancers and infections are more likely to be invasive in this way, particularly fungal infections, I will say, than run-of-the-mill bacterial infections, although when they cause osteo, they can do it. And then we've entertained many times GPA and ANCA positive disorders, and that is conceivable here. I'm less accustomed to them being invasive across the bone, meaning destructive. And I'm going not by my knowledge of the ear and temporal disease, I haven't seen enough of that, but when we talk about uncontrolled diabetes and fungal disease in the sinuses, and we oftentimes have opacification of the sinuses, people go through a large differential, and then as soon as you start to see bone erosion, people really shift gears to raising the concern above an invasive fungal infection above all others. So it's used as a trigger point or trigger sign in an adjacent neighborhood in the head. So I'm just reasoning by analogy here.
And then given his other comorbidities, we had also gotten a venous blood gas to check and see if there was any hypercarbia that had started while he's been hospitalized. It did not show any hypercarbia. He did get blood cultures on admission, and 3 days in, when we were evaluating him, there are no growth to date.
And just a note on those blood cultures, he probably came in the door on some antibiotics, I imagine, or?
Yes. Yeah.
Okay. So at least partially impacting the yield. We don't have a sense that he has an embolic phenomenon like from his heart. I mean, it'd be incredibly strategic for an emboli to go from the heart to the ear, but there's no other spot in the brain. There's no other spot in the joints. There's no other spot in the skin. There's no murmur. So I think, while it would have been nice if the blood cultures gave us the result, there wasn't much expectation that that was going to be the case here, unless the focus of infection has set up shop in his ear. So I think where to go from here, or sorry, spread from his ear, where to go from here, I think you have to basically start doing the testing that relates to each of the categories. And when we do infections, we should just be very methodical, right? There are largely 6 to 8 common classes of infection that we think about. Bacteria, we do by culture. Largely, you can, in certain instances, you can do PCR and antigens. Viruses are generally cultures and serologies. I think the only virus maybe that might be this sort of invasive in a skin-lined area, or it might be like HSV, if there's somehow uncontrolled HSV in the ear, or sometimes we see VZV, right, shingles, etc. But I think we might do viral cultures here. Mycobacteria requires AFB testing and mycobacterial culture. Fungi, we do direct cultures, but then we have this massive slew of things to send, including urine histoantigen, cryptoantigen, cocci serologies. We now have galactomannan and beta-D-glucan at our disposal, so we send those as well. And then once we get into parasites, we really have to have a hypothesis to think of before we just send parasite studies or O&P on the ear. I think I wouldn't find myself doing that right off the bat. And that's how I might expand the current ID workup. I imagine some of it's been done in the past. In the cancer category, I would really rely on imaging and perhaps another biopsy specimen. And then in the autoimmune category, I think the two that I might give some credence to, well, probably one in particular, we talked about ANCA. And then whether sarcoid could do something like this, I think it could be set up shop in the ear. I don't think it's inherently purulent or invasive like this. So I think I might restrain myself and just stick with an ANCA in the autoimmune category.
Really incredible. And well, before Mohit, you jump to the next section, I actually just wanted to highlight a question that Reza asked in the chat about empiric treatment and specifically empiric antimicrobial coverage. So how would you address any treatment at this point before further labs, and specifically antimicrobial coverage?
Yeah, I think, well, we've even talked about the possibility that the antimicrobials are causing harm rather than good.
Right.
So in this case, I'd be reticent to layer on more, right? Like there's no suppurative complication, like to the best of my knowledge, we haven't talked about meningitis, but there's no abscess, there's no thrombosis, there's no mastoiditis. So I don't feel quite an urgency to have antibiotics on today. I'm interested in the experiment of them being removed. And then to enhance culture results, if that's possible for a 48-hour, 24 or 48-hour holiday, I'd almost lean in the direction of stopping the antibiotics and stopping all antimicrobials. So if we could get...
Gurpreet, sorry to interrupt. You had me raised from a supine position to an upright position. Charmin said you learn best listening to Gurpreet in the horizontal position.
Or the static learning, I appreciate it.
Really, My question
I'm
is,
pretty sure I put you asleep when I'm talking.
but you must have, if I'm saying to add antibiotics after you've been saying for 30 minutes to stop it. So my question is regarding antifungal.
Oh,
Did
yeah.
you initiate antifungal is my question.
Yeah, I guess the question would be only if there was a sense of urgency around it. I mean, we've all, like, there are situations in medicine where we give antifungals empirically. You know, neutropenic fever is a great example after 4 to 5 days of non-response, or when, you know, just when we think someone is deeply immunosuppressed and that's the next thing to do, and we have imaging that's suggestive, but we don't have culture results. You know, if I inferred as AMS as a marker that things have gotten worse, I would do it. But if there's a window to get the proper diagnosis, I would favor taking a break on antibiotics and then restarting. It's one of those things you probably have to be there to see how much leeway you have. But I'm worried about another round of empiricism just adding more confusion. And I appreciate you staying upright for the remainder of the.
Going back down, my friend.
Turn off your camera.
Wow.
Hey, Mohit, give us more.
Oh my gosh, no, I'm just in awe of the discussion. This is great. So I will maybe I will share a little bit and backtrack on how the next 24 48 hours progressed from day 3 of the hospitalization before I ultimately reveal how we got to the diagnosis. So the patient got admitted onto my service. I was the attending at the time during my chief year. We started antibiotics per infectious disease, per ENT. And on day 3, like we've been talking about, the patient became newly altered, more somnolent, difficult to arouse. With this, as Gurpreet astutely picked up on the exam, myoclonus and clonus on exam. So by day 4 is when we really initiated a lot of this workup. Day 3, we didn't really pick up on this myoclonus that was there. We just noticed that he was more somnolent. So with his history of OSA, with his history of COPD, the first thing we thought about was hypercarbia. Maybe he just needs improved sleep hygiene with his CPAP that he didn't use for one night while he was in the hospital. When that didn't really come to, we got imaging as discussed. And that day 4 is when we noticed this myoclonus on exam. We, at that point, decided to take him off cefepime and hold antibiotics for 24 hours. On day 5 of the hospitalization, he was gradually improving. He had less myoclonus on exam per his family, but he was still pretty somnolent, really difficult to arouse in the mornings and really napping throughout the day. Infectious disease wanted to switch his antibiotics to Zosyn at that point, covering Pseudomonas given his diabetes. And by day 6 of the hospitalization, he was up in the morning asking for breakfast, wanting to know what in the world he's doing in the hospital for so long. All that said and done, ultimately with infectious disease involved, ENT and our team, we thought that the time course of initiation of cefepime, the clear myoclonus on exam that improved with stopping the cefepime, and then his resolution of symptoms when we got off the cefepime, ultimately led to what many are typing in the chat as cefepime-induced neurotoxicity. Now, getting at the initial question, which Gurpreet and many others have been curious about, is why in the world is this person still dealing with an otitis externa for 2 months? Is there something that we're missing? And like Gurpreet mentioned, and if you look on the CP solvers, there's a fantastic schema for antibiotic failure. We thought along all of those spectrums of causes, but when we talked to his daughter, and this was really day 4 of the hospitalization, we learned that he does not like taking medication. So even though he was prescribed, a 7-day course of Augmentin, he was prescribed 3 times daily up to 4 times daily of Ciprodex drops. He just wasn't doing it. So he never fully completed a single course of the antibiotics that he was prescribed both by his PCP and ENT referral. He would get these debridements, he would go home maybe for 24, 48 hours, take the medications as prescribed, and then would stop. So really, in terms of what caused the antibiotics to fail, we thought it was not necessarily a wrong spectrum or we're missing a particular bug. It's just that he wasn't taking it. And so when we talked with infectious disease, confirmed this story, they felt that these erosions that were seen on the imaging likely represented, or we should at least interpret them as osteomyelitis of the ear canal and of the small bones within the ear canal. So ultimately, they thought a combination of not taking the antibiotics as prescribed, not completing a course, but also perhaps not really good source control, since he ultimately led into what sounds like osteomyelitis. So he ended up going home on IV antibiotics. I blank on exactly which regimen they picked after we switched from Cefi to Zosyn. I came off service at that point, but that is the resolution of the case.
Wow.
Yeah, Gurpreet, what are your immediate reflections here?
Yeah, I think well, one global one. I think the most telling one is patients have all the reasons not to take our medications. I feel bad that when he finally got it, he doesn't like antibiotics. And when he finally got an antibiotic, it caused toxicity. Like perhaps that was one of his concerns at the get-go, and then it becomes a self-fulfilling prophecy because he required admission and got IV antibiotics. I'm glad it was something that was reversible just by taking away the IV antibiotics. But I think maybe the bigger example or the better lesson, which I only entertained partially, I didn't really elaborate on this, and I love it because this is probably the most real world thing of all, is that the wrong bug, wrong drug, wrong host, wrong source control, and inadequate source control oftentimes means like we've underestimated that those drugs are being taken at all, right? So we may think like, well, it's the wrong dose, it's not anti-pseudomonal level, we're giving it PO instead of IV, we gave it too short of a duration. But of course, if it's never taken at all, then none of those considerations matter. And patients are totally human and have their reasons to not take and perhaps not even tell the doc when we ask. So among all the things that are on that list, some of them are exotic. This is probably one of the most pragmatic, and obviously it had dire consequences, but it is something, kudos to the daughter or the team who inquired with the daughter to give that info.
Yeah, and just to give you an idea of his personality, the first day when I met him, when he was completely with it, he complained that he really disliked the coffee at the VA. And that was the first thing that he mentioned to me when he was finally awake from his neurotoxicity, is that I hate the coffee here. I just want to be home so I can drink my own.
And I assume that was a mark of restored neurostatus?
Yeah, I think so. At that point, at that point, I was assured. It's like, okay, we've got him back to baseline.
Yeah, very
really incredible.
telling.
Yeah, and Mohit and Gurpreet, I'm curious from either of your experiences, if you've seen, HEPA-induced neurotoxicity before, are there certain risk factors in patients that who are more predisposed to developing this, or is there not? I'm just curious if you know any more details about that.
I can share what I know, and perhaps Mohit looked at it in detail. I think the biggest risk factor is probably age is linked with it, I suspect, but I know that for sure. I do know that many cases and case series have concomitant AKI. So a drop in the GFR is responsible for an excess of it. And there's probably some predisposition in other dimensions. That's why I was almost anticipating it, but like all things that are characteristic, it doesn't mean that they're synonymous or necessary. So that I think is one of the more common things that comes along with it. It's very, I have seen it too. I'm in the same way. It's something I'd never think of on day 1 or 2, and then day 3, like either our thorough AMS workup is striking out, or something happens like myoclonus, or just someone much smarter than me around the team notices like the bag of cefepime hanging. And those are the ways that we oftentimes get to the diagnosis.
Yeah, and Maddie, that I concur. Renal impairment, whether it's acute or chronic, is one of the biggest risk factors, along with age. I was even reading when I had this case in chief here that up to even 10 to 15% of ICU patients who are admitted and get cefepime get some spectrum of neurotoxicity from cefepime. And it can be a huge spectrum. It can really be from this, where it is just somewhat of a delirious status or, somnolent status, all the way to press. And I've seen a case of press in the ICU. So I think maybe my recall bias at this point makes me think about it every time I see someone getting newly altered in the hospital. I think about cefepime, or I think about some other antibiotic. Are we doing this to them? But as always, Gurpreet had such an amazing methodological approach to thinking about this case.
Great pleasure. This is great fun. I will say the antibiotic thing, I think almost it's so counterintuitive because we give antibiotics as a way to help people, right? But I have seen it with quinolones causing sort of a delirium state, cefepime in this neurotoxic state. You'll see it. I've seen an ertapenem, which was a diffuse encephalopathy that led someone to comfort care. And when the antibiotics were stopped because they were in comfort care, they completely resolved. And then there's a version that I've only seen in case reports, not personally, of metronidazole doing it. And that causes a direct toxicity, I believe, in the cerebellum and the dentate nucleus, which I think is a structural change and perhaps not as easily reversible. So it's not, cefepime, I think, is sort of the, it's got a lot of buzz as of late, but I think there's a whole suite of antibiotic associated encephalopathies. So this is a good reminder for a bigger issue to keep track of.
Yeah. And Gurpreet, in the final minutes, one question I wanted to ask you is, whenever you deal with altered mental status cases, whether in real life or in VMR, does the words like somnolent, drowsy, difficult to arouse, does that influence your differential diagnosis in any particular way, or is that not really helpful?
So I'll say the short answer is no, and I might get hate mail from a neurologist, because I know neurologists want us really to characterize, like what is it exactly that you're contending with. I have found that oftentimes those descriptors are just, they're so adjacent to each other that the chance I'm going to like knock off one of those categories in the workup because they are like, I don't know, somnolent and not agitated or something, it's never been very functionally for me, at least in the places where I am, like the ER or the hospital ward. There may be certain settings where the characterization is precise. I mean, to give you an example of precise characterization, sometimes you'll see neuropsych testing, which is a huge battery of tests, and they very eloquently describe, like, these are the neuro impairments. This executive function doesn't work. And I think at that level, there probably is some value in saying these categories of disease don't do that. But I think what we see oftentimes at time zero, staying broad, I think is very hopeful.
Amazing. And I just, Mohit, I want to thank you for walking us through such a fascinating journey. You really kind of had us at the edge of, at least me, at the edge of my seat at each aliquot. And Gurpreet, really, it's kind of a privilege to hear you talk out your thinking. And I love at the end, you walk through this amazing approach of, ear disease without improvement, wrong bug, wrong drug. But at the end, you highlighted, that schema is so wonderful, but you have to make sure they're taking the antibiotic in the first place. So you just gave so many pearls, and I learned a lot about antibiotic neurotoxicity. So just thank you so much for taking the time to be here.
The pleasure was all mine. Thank you.
And Sammy, thank you for scribing. And Kiara, we would love to hear your teaching points.
Yes, of course. Thank you, Malina. So this was a very beautiful case and very beautiful presented. So we started with altered mental status and our great approach of MIS pneumonic, which is metabolic infection causes, structural, and toxins. And then Dr. Gurpreet literally narrowed all the diagnoses in the first aliquot, and his first question was, why is this ear disease is not improving? So he said that first, we have to think that this can be a wrong bag or the wrong drug or a source control. For all of this, for this last one, we have to check if this patient have a okay immune system, or maybe he has malnutrition, or maybe he's taking any drug that make his immune system go down. And also we have to check if the original diagnosis was correct. In this case, this was wrong. This was kindly a wrong drug because this patient wasn't taking his drug. And one point I have, once I read that polypharmacy, which is this case patient, is a great risk factor for non-compliance for medication. So maybe this was kind of the case. Then we have to think about where can this infection go. So about the infection spread, this bag can go to the mastoid or the temporal bone or the brain. So this was our first approach. And then we go back to altered mental status. And as this patient had many comorbidities, maybe first we have to check the glucose level. Maybe this was up or down, his saturation, because he also had COPD. So many drug associations, because there are group categories that can develop encephalopathy, like beta-lactams or quinolones or metronidazole. Also, he was very susceptible for AKI. So, for example, gabapentin induced. So we also had to check this on this patient. Then we narrowed the diagnosis with infection versus cancer. And one fun fact was that, not fun fact, one important thing was that in St. Louis, where this patient lived, is ehrlichiosis and blastomycosis is very prevalent. And also one fun fact is that I developed my obsession for apricots in St. Louis. So I love St. Louis. And then we also have to think about occupational exposures that can develop into cancer. After that, Madelina asked a great question. So it was how we make progress here. So Dr. Gurpreet nailed in the exam because he wanted to know about the ear exam and the neuro exam. And about the neuro exam, he wanted to check the neck and the cranial nerves. Why the cranial nerves? Because when we have ear compromise and cranial nerve involvement, this is like a door to a cranial compromise. So this was very important. And finally, we had some images and we found that there was an erosion. So erosion for Dr. Gurpreet equals destruction. And why this patient can have destruction? First of all, can be cancer, infections, especially fungi or autoimmune. So the workup was based on all of this. And our surprise was that this patient wasn't taking his medications, which is a common thing because it's very common for patients not to take his medication, as I previously told, especially if they have many medications to take. So yeah, amazing case, a lot of teaching. I love this case so much, and expert discussion.
Kiara, I loved how you walked through those teaching points and associated it to each part of the case. That was really brilliantly done. Thank you for sharing. And thank you for everyone for tuning in. We'll see you on the next VMR.
Bye, everyone. Thank you.
Bye, everyone. Thanks, Gurpreet. Thanks, everyone.
Thanks, Mohit.